We have seen anesthesia for liver disease in a general way. Now let us go into specific etiology or obstructive jaundice. What is jaundice? Jaundice is nothing but increase of your serum bilirubin, right? We'll see visible jaundice if this serum bilirubin is greater than 2 mg per TL. If it is between greater than normal but less than 2, it is nothing but your latent jaundice. Let us see normal bilirubin metabolism. Your hemoglobin after catabolism gives heme. The other sources of heme are myoglobin, cytochromes, and ineffective erythropoiesis. This heme is converted into biliverdin and later into bilirubin. So the enzymes which help in this conversion are heme oxygenase. That means it converts heme into biliverdin and biliverdin reductase. Its substrate is biliverdin. So biliverdin reductase, it converts biliverdin into bilirubin. This bilirubin, which is unconjugated one, it enters plasma and combines with albumin. It is just combination. It's not conjugation. Okay. It combines with albumin and next it enters the hepatocyte. Okay. In hepatocyte, bilirubin and albumin get separated. This bilirubin with glutathione S transferase, which is also called ligandin in the endoplasmic reticulum with the help of bilirubin UDP glucuronide transferase enzyme, it forms bilirubin monoglucuronide and diglucuronide, which is nothing but finally your conjugated bilirubin, which is water soluble. This might again get bound to albumin either in a reversible manner or irreversible manner. Keeping that aside, this conjugated bilirubin comes out of the bile canaliculi and enters your intestinal lumen. In the intestinal lumen, what happens with the help of intestinal bacteria? There is urobilinogen and stercobilinogen. This stercobilinogen gives your stool the color, and the urobilinogen is reabsorbable and again it reaches the liver. So from intestine, it reaches the liver through enterohepatic circulation. And from liver, what happens is it might again reach the intestine or go into the renal system and gets excreted. Okay. So, heme, biliverdin, bilirubin, conjugation and into intestine, there's stercobilinogen and urobilinogen. Urobilinogen again into enterohepatic circulation, from there again into intestine or to the kidney. So, this is bilirubin metabolism. Why there is jaundice? Either first there is increased production of bilirubin in the first place, or there is decreased uptake by the liver, or next stage, what is the next stage? Conjugation. There is decreased conjugation. Okay, there is conjugation has happened. Now what next? There is obstruction. There is cholestasis. So these are the four problems which causes jaundice. The causes of increased bilirubin production may be hemolysis, that may be intravascular or extravascular, or decrease hepatic uptake by due to prolonged starvation, sepsis, and dissociation from albumin and its binding to ligandin gets affected. And thirdly, decreased conjugation. It might be due to acquired or hereditary disorders like Gilbert's Kriegel-Nasser and acquired is hepatitis, cirrhosis, drugs, toxins. So all these cause predominantly unconjugated hyperbilirubinemia. Coming to the last cause, conjugation has occurred, but there is cholestasis due to either intrahepatic or extrahepatic obstruction. The cause is specific etiology may be Gibbon-Johnson's, Rotor syndrome, hepatitis, again cirrhosis, and mechanical obstruction. Something is obstructing like your CA carcinoma of CA of pancreas, gallstones, strictures, sclerosing cholangitis, tumors any around bile duct or pancreas. So this particular cholestasis causes conjugated hyperbilirubinemia. Okay. So there is prehepatic, hepatic and post-hepatic causes. In prehepatic, you will see unconjugated hyperbilirubinemia. In post-hepatic, that is obstructive cholestasis, in that you will see conjugated hyperbilirubinemia, and in the hepatic cause, you will see both conjugated and unconjugated hyperbilirubinemia. So, coming to the obstructive jaundice per se, what is the pathway? There are intrahepatic ducts. The right and left hepatic ducts, they form the common hepatic duct. This, along with cystic duct, it forms common bile duct. This common bile duct with pancreatic duct at ampulla of water, it opens into second part of duodenum. Okay. If there is pancreatic cancer, there will be obstruction at this periampular region. So what happens if there is obstruction? There is cholestasis. There will be decreased fat absorption. So fat soluble vitamins are deficient in those individuals. And secondary to it, there will be infection. Okay, so these two, obstruction. So there will be back pressure. There will be deficient fat soluble vitamins and there will be infection. So back pressure, inadequate excretion of bile, colonization of gram-negative bacteria, and this enterohepatic circulation is affected, causing inadequate fat absorption. Fat soluble vitamin deficiency is seen, and there will be defective elimination of toxins because it is not going to intestine and then excreted. Okay, so there will be weight loss, and due to deficient clotting factors, deficient water soluble vitamins, which is vitamin K, there will be derangement in the activation of vitamin K dependent clotting factors. Okay. So these are your effects. Vitamin K deficiency causes coagulation abnormalities and BP is raised. And due to obstructive biliary system, if we leave the obstruction in such a way, it will lead into liver failure. Now I have removed the obstruction. There will be sudden release of endotoxins into blood, causing your septic shock. So if we release, there will be sudden endotoxemia and septic shock. So definitely you have to give a proper antibiotic coverage. Other system effects, this we have already seen in renal, there will be direct toxicity to renal tubules due to increased bilirubin, and the patient might land into decreased urine output and aka HRS. So our main goal is to prevent hypovolemia and you have to maintain urine output. CVS, of course, there will be negative, this increased bilirubin have negative effects on heart, like negative inotropic, negative chronotropic, and the sensitivity is impaired. The baroreceptor sensitivity is impaired. And also there is down regulation of cardiac beta receptors, and finally the BP is decreased, PVR is low, and also they become insensitive to vasoconstrictors, both endogenous and what you give from outside your noradrenaline and all. Okay. Coming to GA, we have seen that will be malabsorption of fats. So there will be steatoria, fat soluble vitamin deficiency, night blind for vitamin A. There will be night blindness for vitamin D, osteopathy. But for vitamin E, there is neuromuscular weakness. For vitamin K, clotting defects. And there also will be stress ulcers. So for this patient preparations, you can avoid prolonged NBM and give 12.5% maltodextrin carbohydrate drink because it decreases insulin resistance, it decreases thirst and fatigue and increased feeling of well-being, so that the post-op recovery, the patient will be satisfied. What we'll do, if we are giving it on day before surgery, we'll give 2 sachets in 800 ml water, and on the day before 2 hours, we'll give 1 sachet in 400 ml. We should be cautious that it has to be completed before 2 hours prior to surgery. And we have to confirm his diabetic status. We'll be giving generally in non-diabetics and in the patients where there is no gut motility disorder. In diabetics, if we want to give, we have to see that if FPS is less than 200 and under strict blood sugar monitoring. And apart from that, in generally we'll give prokinetics, your anxiolytics, and be careful with the serum bilirubin. We have to check serum bilirubin because it is one of the important prognostic factor for post-op recovery. And the vitamin K, FFPs and platelets will be optimizing coagulopathy status of the individual. So for obstructive jaundice per se, the poor predictors are if the cause is malignancy, if the age is greater than 75 years, and the serum bilirubin is less than 3, if there is increased serum creatinine along with increased total serum bilirubin, and if the total serum bilirubin is greater than 17 mg per dl, and chronic malnutrition. Pre-op investigations are same we have seen priorly, and monitoring. Apart from the routine monitoring, we might add flow track monitors to monitor your SVB and PVB, stroke volume variation and pulse pressure variation. Next, for depth assessment, we have seen you can go for neuromuscular monitoring or breath monitoring. Intra-op management, if there is obstruction, this is obstructive jaundice, right? And if the patient is complaining repeated vomitings and obstruction, we have to go for rapid sequence intubation. And in these patients, there will be increased endogenous enkephalin. So pain sensitivity is decreased, pain threshold is increased. So we can give lesser amount of opioids. And the main thing is we have to avoid spasm of sphincter of OD because your fentanyl, morphine, they cause spasm. Again, there will be obstruction. So we have to give in a reduced doses. And this spasm is treated by halothane, which we are not using up, enflurane or naloxone or glucagon. So in obstructive jaundice, please remember this extra point. Fluid management, obviously goal directed, because if we overload the patient, he might land into bowel edema. Normally, we'll be going for 4 ml per kg per hour, depending on fluid responsiveness. If we have SPB monitoring, we'll either increase or decrease the fluid. And pain, we'll be avoiding morphine in liver disease patients, so we'll go with fentanyl. But in some places, what they'll do is they'll give epidural morphine. Okay, because epidural morphine is more potent, right? It is more potent than fentanyl. So, due to increased potency, we can use decreased amount of local anesthetic. So, hypotension can be prevented. That is individual choice, but it is preferable to give IV fentanyl rather than IV morphine. Extubation, of course, we have to check for hemodynamic stability, adequate recovery, normothermia, no sepsis, normal lactate levels, and no surgical related complications. So for obstructive jaundice, we'll be writing about the causes of obstructive jaundice, the pathway, and especially your monitoring, flow track monitors if it is prolonged procedure and if you are expecting more fluid shifts. Okay. And the main thing is prevention of spasm of sphincter of OD and the effects, because there is a chronic malnutrition, there is vitamin K deficiency, they might land into coagulation defects. So we'll be keeping in mind everything and we'll proceed for the surgery. Okay. So a small word about acute liver failure before going into liver transplantation. If we hear the word acute liver failure, two things should come in mind. One, it is acute. Okay. And second is liver failure, right? Acute means it is not chronic, right? So it is less than 26 weeks and no previous liver disease because it is acute. Okay. There shouldn't be any previous liver disease and it should be less than 26 weeks. The symptoms. Liver failure symptoms mainly there has to be encephalopathy and coagulopathy. Okay. So these three things you have to remember. Acute liver failure. In liver failure, you will be remembering encephalopathy and coagulopathy. Acute, it has to be less than 26 weeks and there is no previous liver disease. Okay. So coming to etiology, drug related most common which is acetaminophen and idiopathic acute viral hepatitis, autoimmune, ischemic and Wilson's disease. In that, acetaminophen related acute liver failure, hepatitis A related acute liver failure, and ischemic. These three have favorable prognosis. Examination, we'll be seeing for etiologies if there is any history of drug poisoning, if there is any recurrent medication, potential infections and all. And we won't be seeing the signs of chronic liver disease like what we have seen ascites, signs for portal hypertension, because there won't be time to develop all those things. So lab investigations, same routine investigations that we have seen for liver disease patient. And in addition to that, we'll be seeing the investigations specific to the etiology like acetaminophen level, anti-hepatitis A virus, immunoglobulins, HPSAG, viral markers, uh, ultrasound serum, amylase lipase, and your ANA. Pathophysiology. So, two main systems are involved along with all other systems. The two main are your CNS and coagulopathy system, right? Your hemostasis system. In CNS, it is hepatic encephalopathy. We have already read about hepatic encephalopathy. What will be there? Cerebral edema. Because there is increased ammonia, this ammonia is converted into glutamine. And this glutamine is osmotically active. So it is causing cerebral edema. And we have four grades. Westhaven's classification. Grade 1 and 2 are less prone for cerebral edema, and grade 3 and 4 are more prone for cerebral edema. So, what is your target? Is to decrease ammonia or decrease the cerebral edema. Prevention of increase in ICP, right? So, what we'll do? We'll keep head up position, 30 degrees head up position. We have to prevent coughing, bucking, which increase the raised intracranial pressure. We might use barbiturates, but we have to see for hypotension. And the main thing is to reduce the cerebral edema, we have two options, mannitol and hypertonic saline. The disadvantage with mannitol is we shouldn't use in renal failure patients, right? So, we'll go for HTS in renal dysfunction. If we have to use mannitol, we have to remove twice the administered volume of mannitol in hemodiafiltration. Next, we have to maintain normocardia, and hyperventilation will be not, we won't do it routinely, but we'll reserve in resistant cases, okay? Or for response for acute, if there is acute increase in ICP, then we'll go for hyperventilation. And the main thing we have seen already in hepatic encephalopathy, we'll go for lactulose, rifaximin, or neomycin, but neomycin is again contraindicated in nephrotoxicity. We have to give prophylactic antibiotics. There is a study, US acute liver failure study. They say that we have to definitely give prophylactic antibiotics when there is surveillance culture which really significant bacterial or organism isolates. If there is progression of the grading, stage 3 or stage 4 coma, if there is refractory hypotension, and if the patient is in CIS. And these two we generally forget, but please remember we have to maintain modest hypothermia and we have to maintain cerebral perfusion pressure also. Okay, we have, of course, we should see that there is no increase in ICP, but we have to maintain cerebral perfusion pressure. So, for acute liver failure, regarding encephalopathy, what we'll be doing is prevent raised ICP, prevent bucking, prevent irritability, prevent coughing, keep head up position, go for rifaximin or lactulose because neomycin it's not indicated in renal dysfunction. Go for mannitol or HTS depending on the patient condition. Maintain hypothermia and maintain CPP. And do not forget antibiotic coverage. Coming to coagulopathy, the correction or treatment for coagulopathy depends on the situation. If whether the patient is bleeding or not, or whether any procedure is indicated for the patient. Okay, if the patient is bleeding or the patient has to go for invasive procedure, you have to maintain your platelet levels at least greater than 50,000 and INR less than 1.5. If the patient is not bleeding, you don't give prophylactic platelets. We have to give platelets if there is any indication like abnormal decrease in platelets like less than 10,000 or bleeding or abnormal increase in INR. Otherwise, for resistant cases, we can go for recombinant factor 7A concentrate and prothrombin complex concentrates. Okay. coming to other systems, CVS, we know there will be hypotension and myocardial dysfunction. So we'll have to go for fluid resuscitation and BP maintenance by vasopressors or inotropes. For renal, there will be oliguria. First, we'll try to prevent it. If it occurs, we'll go for uh, hemodiafiltration. Respiratory, we have to see the consciousness of the patient. We have to go for intubation to protect your airway and aspiration, and specific treatment for the etiology. If it is paracetamol overdose, we have to go for NAG. And we'll see the grading of acute liver failure, how much severe it is, and then we'll proceed for surgery. If it is so much severe, grade 3, grade 4 hepatic encephalopathy, severe sepsis, we'll be postponing the elect. Of course, we'll optimize and then go for surgery.